Welcome you all again to our today's webinar on the COVID impact on urban informal settlements, vulnerabilities, challenges, and responses. So this webinar is hosted by BRAC's Chairperson School of Public Health, BRAC University, and Arise Bangladesh Hub is organizing this project. So before starting the webinar, I'm going to just talk a little bit about what is Arise project. So Arise is a multi-country research consortium operating in 4 countries: Bangladesh, Kenya, India, and Sierra Leone. So this project is mainly focusing on the governance and accountability and health and well-being systems in urban informal settlements in 4 countries. So today we are very fortunate that we have with us Dr. Hossain Zillur Rahman, the chairperson of BRAC and executive chairperson of the executive chairperson of Power and Participation Research Centers, and he is also the advisory board member of Arise Bangladesh. We have also have different speakers from 3 different countries. So the speakers are from Kenya. We have Dr. Lilian Otiso. She is the executive director of LVCT Health and based in Nairobi, Kenya. She is a medical doctor, and also she has been working in the health sectors at clinical and program management for more than 14 years. We have speakers from India, Varun, who is the research assistant at the George Institute for Global Health, India, and based in New Delhi, India. And he is a researcher having interest in informality, technological changes and societal perspectives, and also political economy and health and information communication technology for health. Our second speaker from the India team is Smruti Srinivas Jukur. She is an urban planner and architect and working with SPARC India. And she has years of experience of working on solutions, working on developing feasible solutions for the urban poor who are living and working in informal settlements. And then we have 2 speakers from Sierra Leone. So the first speaker from Sierra Leone is 𝐕𝐮𝐻𝐿𝐽𝐻. He is an urban health research officer and working with the SPARC at Freetown, Sierra Leone. And he has been working in research, conducting research for many years. And his interests include environmental management, health system research, and socio-political practice. And all of the research work is mostly with underprivileged people in his country. And then our last speaker from the Sierra Leone is Samuel Saidu. He is a research assistant and working at Comas, University of Sierra Leone, Freetown, Sierra Leone. So he is a pharmacist by training and also a public health professional. And he has been working in Sierra Leone in many health research projects, including vaccine trials as well. And all of them are working in their respective countries with the Arise project. So I myself, Basira Akhtar, the Assistant Director at the Center of Excellence for Gender, Sexual and Reproductive Health at Chairperson School of Public Health in Dhaka, Bangladesh, welcome you all to our webinar. And I also would like to welcome our speakers and chair. So now I would like to request our chair, Dr. Hossain Zillur Rahman, to say a few words and start today's session. Zillur bhai.
All right. Welcome from my side too to everyone, both in Bangladesh and in Kenya, Sierra Leone, and India. I think this is a very important webinar that James B. Grant School of Public Health is organizing. COVID-19 is on everyone's mind. And in terms of a focus on a particular segment, which is urban informal settlements, we'll have a closer look on this from 3 country presentations. And I think it will be a great opportunity to try and come out with ideas, how things are happening in other countries. And the importance of this webinar for me is not just that we are doing a research reporting, it's a real-time intervention in thinking process. I think the inputs coming out of this webinar can provide inputs to a wide range of stakeholders to think about how to address these particular segments of the population living in urban informal settlements, certainly with their health issues, but also with related other issues. So I think from my side, that would be like a welcome remark. We may get started. I know that we have a tight time frame of 2 hours. So I would welcome and ask everyone that let's make the best use of this time. Over to you, Bashira. Over to you, Bashira.
Yes, thanks, Dr. Rahman. So before starting and inviting the speakers to share their experience, just for all the participants who are joining with us today, we please, if you have any questions during the presentation or after the presentation, please write on the chat box in the Zoom. And also those who are joining with us through our Facebook page, please also post your questions as in the chat box. So for managing the whole webinar, we are very sorry that we cannot allow anyone to actually speak, but we will take the questions from the chat box. So now I would like to welcome Dr. Lilian from Kenya to share her experience in her country. Lilian, over to you.
Okay, thank you very much, Bashira, and thank you for organizing this webinar. We want to share today our experience of implementing programs among our key and vulnerable populations in marginalized areas in Kenya. So I want to just take you through what that looks like for us and our populations and explain everything and about LVCT. So my name is Lilian Otiso, as heard, and I'm the Executive Director at LVCT Health. I'm also in charge of our program in LVCT, the ARISE program, involved in informal urban settlements. And I hope we had a national curfew and advised to stay home. So most people are supposed to stay home, but it's not a total lockdown. It's a partial lockdown with restricted movement in and out of 5 affected counties, Nairobi being one of them. And all the bars were closed. All churches and places of worship were also closed. And though public transport continued, only half the passengers are allowed to travel at any given time. So that resulted in increased fares. Everybody must wear masks when they walk out. And then the prevention practices that have been ongoing are still encouraged everywhere we go. So I'll give you a sense of, next slide, please. In the next slide, I'm talking about LVCT Health. We are a Kenyan NGO, and what we do is mainly provide comprehensive HIV prevention and treatment programs, sexual reproductive health, and gender-based violence services to marginalized populations. Our priority populations are adolescent girls and young women, key population who include men who have sex with men, sex workers, and people who inject drugs. We also serve the general population who are at risk of HIV. And all this work we do in various counties, but mainly targeting the urban informal settlements and also the rural areas where there's a lot of poverty. And the services are both at community and facility level, working with the Government of Kenya facilities, but also delivering outreach services in different setups. So next slide. So when it comes to COVID and how the country has responded and what it is, I'm going to talk more about how this has been in the informal urban settlements in Nairobi. Nairobi has about 60% of the dwellers living in slums or the informal settlements. And the key challenge when COVID came was how do you implement the prevention interventions in very densely populated areas with poor sanitation, a poor road network. So that has been the challenge that has been ongoing. And but all these measures that were put in place have been affected or implemented everywhere. And some interventions have been put in place to make sure that there's disinfection, like the picture you can see there, hand washing facilities that the traders are supposed to put up, and people put up hand washing within their homes as much as possible. But we've seen challenges arising because of this. There's significant challenges with loss of income. Even if businesses were not shut down completely, there are many that were shut down and people lost their income, and many live on a day-to-day basis. So this has also resulted in lack of food and high transportation costs to get from one place to another. we've seen a lot of violence through the enforcement of the lockdown and increased crime in neighborhoods, especially during the curfew period. That has also resulted in increased gender-based violence, including physical violence and rape, as I'll show in the slides that are coming up, and high risk of unwanted pregnancies. One of the key issues we've had to address is the myths and misconceptions that have come up regarding COVID, including it doesn't exist, doesn't affect Africa, it's just a government strategy. And those are some of the key challenges that are affecting the implementation of the interventions, especially in the slum areas. Next slide. So specifically on the health risks and challenges we've noted, right from the beginning, there was a challenge with accessing health facilities. The health workers did not have the preventive equipment, protective preventive equipment, so they feared handling clients who would come in. And the result was that some people were turned away. This has been improving, but there's still challenges with accessing services. Then there's also trying to maintain the social distance or physical distance. So people sometimes have been turned away when they seem to be crowding in a facility. There's also fear from the community of going to the hospital due to fear of contracting COVID. And stigma has come up around COVID, especially because of quarantine that is forced. And initially people were being told to pay for quarantine. So there was a lot of stigma that came up around COVID or being diagnosed with it. We're not able to carry out our community outreach programs, including HIV testing and counseling, defaulter tracing. So that has an impact on some of the programs that we deliver. And because of people being unable to either pay for higher cost of transport or being locked out of the counties that are locked in, that has affected their ability to come in for their routine services, including the HIV services. And for those who have NCDs, then getting those services has also been challenging. Next slide. I mentioned the gender-based violence. We've seen increased cases of gender-based violence being reported. The data from our programs has shown that we have 4% cases of, and this is just reports for 2 months, which was an increase compared to the previous 2 or 3 months that we had been reporting this data. And
Lilian, we cannot hear you.
Violence was about 33%. So that we can see that it has already started rising. And we analyze the perpetrators, and we see that family are a major source of violence. And this is all for all forms of violence. So the family members, because of people now being together for a long time, unemployed, we're seeing this really coming up quite a bit. And the partners that they're living with, as well as the neighbors, being the more common. So these are all the effects of the containment that we're seeing. Excuse me. Next slide. So on this slide, on the next slide, I'm talking about what LVCT has done. We've implemented education. We've implemented different interventions to try and mitigate against this. So the first priority has been educating the public and the people we work with. So we mentioned, we work with community health workers, peer educators, mentors to reach the populations I talked about. And our first priority was to educate them on COVID and what it means, and to serve as ambassadors to their people that they'll reach out to. And they've been able to do this. We would meet them in small groups and do the training, and they've been able to deliver that. Then we also send bulk SMS to reinforce the COVID messages, as well as HIV and GBV, which we've seen are starting to rise now as the COVID issues continue. We've hosted webinars with youth in informal settlement and informal settlement dwellers, and we continue to share and collect data and credible evidence on COVID that we hope will be able to inform the response. Next slide. We've continued to provide services. We didn't close any of our sites. They remained open, but they have also been affected by COVID, the curfew. So we have to close earlier. When before we would close at 5 or even 6, now we are closing between 2 and 3. Then we have to mitigate against people not having their monthly ARV supplies. We gave multi-month antiretroviral therapy, pre-exposure prophylaxis, and even condoms. So up to 3 months, because that is what we had in stock. And the government has been able to ensure sustained supply of ARVs, so we're not seeing people lacking that. The only challenge is, as I mentioned earlier, those people who were locked out due to the containment, or find that the cost of transport is high, or those who are just afraid of coming into the facility. But we've also made sure that for those who want it, we're able to send them the ARVs through courier services. We provided hand washing facilities in all our sites. As I mentioned, they're based in informal settlements. So we made sure that the hand washing facilities were provided and constantly stocked up, and anybody who needed to use that could be able to use it. HIV prevention commodities have been distributed through peer educators and community health workers up to the community level. So for example, things like condoms and lubricants continue to be delivered. The GBV issues coming up strongly. We've worked with paralegals and also our counselors to work with the communities to address that. And we're also sensitizing the community health workers to do this. So mental health is another issue that is coming up. And we have a hotline service that is able to receive calls. And we've been getting calls on some mental health issues, and we provide telecounseling support for that. And finally, a lot of our clients have called to ask and to request if they could be provided with food. That's their biggest need. They're hungry, they don't have jobs, they can't even pay rent. So we're working with internally, we are trying to fundraise among our staff, but also externally for food, so we can give, especially the key populations. And here I mean people like sex workers who are not able to now go to work at night due to the curfew, so they're not earning an income, and therefore they're also exposing themselves to high risk levels. We also have patients who are living with HIV who don't have food, and we know that is essential. So we've prioritized those as some of the groups, and the adolescent girls and young women to provide this food and resources. Masks are also, because they're compulsory, and the question coming from the community is, should I buy food or should I buy masks? So they don't see the priority of that. And yet the fine for not wearing a mask is about $200, which is quite steep for most people, and others are being jailed for it. So we're also working to support our communities with that. So that's just a sense of what is happening. Next slide is giving some resources. We've been able to update and provide information on our website, and other people to reach out and give this information. And we are continuously collecting data to see how we can be able to respond to COVID and work with our donors and government. We are in technical working groups with the government on the response itself, and we continuously share that data. Thank you very much. I think the last slide just has our contacts in case you want to reach us. Thank you.
Thank you very much, Lilian, for this wonderful work that you are doing in your country. Now, I would like to request India team to share their experience. Varun and Smruti.
Yeah, thank you. My internet is really bad today, so apologies if I mute if I stop my video from playing. So I'm Smruti. I work with SPARC, and I am co-sharing this presentation with Varun Sai, who works with the George Institute TGI, and we will be presenting the situation, what it is in India, and what indicators of marginality are evident from this entire crisis, and if something could have been done better. So next slide, please. So giving a brief about what the situation is, the Indian Union government declared a nationwide lockdown for 21 days, like most countries here, which it started from 23rd of March, which has been extended twice for 2 weeks till then, which makes a total of 42 days. And there is an uncertainty that this may continue as we know it. Now, a sudden nationwide lockdown created a vacuum, especially in the cash flows for both formal and informal economies. International Labour Organization puts the share of informal employment in India to be 85%. That means there's a very huge dependency between the informal and the formal. See, among the vulnerable, let's look alone the poor, homeless, pavement dwellers. The migrants especially have been affected the most. So for about 40 million interstate workers who travel between states are away from their home and have been stuck in cities where they used to work. And this includes mostly single men, but also children and women. Now, the informal nature of jobs and hand-to-mouth living have no formal contracts, no fallback mechanisms, no savings or insurance to support their needs in terms of this crisis. Now, this unplanned lockdown was a shock to their incomes, but also prolonging lockdown has naturally led them to move back to their home, to their villages. Now, the precarious lives at this point were, we see scenes of families moving with their little belongings and journeying thousands of kilometers on foot with very little assurance of food, water, or any other support. The other situation that we've seen is that among slum dwellers, especially who are settled in cities with their families, is also no better. Much of them are engaged in the informal sector and have been without incomes during this lockdown. Families living in slum and relocated colonies also have faced similar challenges, since their marginality improved conditions through offering them better protection from the epidemic. Livelihood dislocations have affected them as well. Now, COVID affects everyone the same. The resilience and response in this situation is not the same for all of them, though. Now, this crisis has also brought out challenges of day-to-day realities of slum dwellers, especially in access to basic services in dense settlements. So, for instance, in Dharavi in Mumbai, many community toilets do not have adequate water, and social distancing is just very impossible. It's so difficult to expect people from 7 to 8 people living in a small shack with 10 by 10 room size. So with this, I think we could look at the challenges that the waste pickers have. Can we move to the next slide, and maybe Varun can take over here now?
Thank you, Smruti. So the situation of the waste pickers at this point of time, we've seen as how the lockdown has highlighted the long-term neglect of communities working in the informal economy. And definitely the waste pickers are one of them. For the waste picking communities in India, the lockdown comes with a lack of safety nets and welfare measures. And this has resulted to a situation with no work, no income, and savings on the verge of exhaustion. And this has put an extreme dependency on civil society organizations for food and also information regarding the epidemic, which includes what is it and what are the preventive measures in place. The uncertainty of when the lockdown will end and how the waste picking communities will be involved in the markets and workplaces remains largely unknown at this point of time. Despite the work that they do, that is being crucial players in keeping cities clean and protecting the health of its residents, sanitation workers and waste pickers are not recognized as frontline health workers. But what they receive at the end of the day is appreciation through garlanding and applause. I mean, it is welcome, but what is required is an effort to change the precarious lives and working conditions. Can we go to the next slide, please? So with no time to prepare or save any money, like said earlier, the daily needs during the lockdown of the waste picking communities have largely been associated with civil society organizations. So civil society organizations carrying out relief works remain the main point of contact when it comes to sourcing information and also relief materials. Even though the waste picking communities have ration cards, which is a basic requirement to access welfare provisions like public distribution systems, it doesn't seem to be adequate enough at this particular point of time. The government is also coming up with interventions to provide ration cards on a prompt and promising note, but it seems inaccessible to the marginalized communities as they require an internet connection and also a smartphone which is charged, and electricity and internet seems to be a luxury also at this particular point of time. And you can also see how the state missionaries are also dependent on the civil society organizations in order to reach the marginalized communities. And it's organizations like Dalit Belgian Resource Center, DBRC, Hasragala, who are on the forefront trying to reach out to waste pickers, sanitation workers, and migrant workers. There is also a huge information asymmetry with respect to the proper guidelines, what could be done at this point of time. So if we look at the centralized mode of governance, it has caused a huge confusion on what is allowed and what is not, and when can livelihoods resume, and when will life be back to normal. So it is a situation where people are waiting with no access to proper guides and guidelines and forced to look into uncertainty. Can we go to the next slide, please? Now, for the waste picking communities, there has been a historical experience of being excluded and neglected. Now, this has a lot to do with the intersectionalities in place. And what that has resulted into is how an already distant healthcare service systems is now further away, and there is limited access to health systems at this particular point of time. And if we look at the settlements, the informal settlements of waste picking communities, as water shortage, poor quality and congested housing, poor sanitary conditions, and this affords little scope to practice physical distancing or self-quarantine. Now, when we know that washing hands is one of the way out, sourcing water itself is a huge issue. And that results in huge lines, queues, with very little scope for physical distancing at this particular point of time. Now, the larger question that is being raised is around governance and accountability, and why this reality has not been forced into COVID-19 preventive measures. Questions also remain why no alternative safe spaces where physical distancing can be practiced with access to welfare schemes is not being put in place. And we know at this particular point of time that slums in Mumbai and many other industrial towns are soon becoming hotspots. And what is present is a mammoth task to contain its spread. It's back to you, Smruti. One of the largest points, what we can see over here is the agency of the waste pickers. So collective bargaining has helped and is facilitating waste pickers and sanitation workers at this particular point of time. So if you look at collective bargaining, one of the biggest examples is how the Safai Mazdoor Union in Shimla, with whom we work, is an example. You know, they were able to demand PPE and sanitizer and continue their work with prompt and responses from the municipal authorities. So that's from my side. Back to you, Smruti.
By the host.
Hi, Shruti, please continue.
Yeah, I was waiting for the host to unmute me.
Okay, sorry.
All right.
Yes,
So, so does this give us some simple ideas of what could have been done? Yes, it does. So most important is to acknowledge that cities are largely informal, and informality in developing countries is here to stay and are the essential engines for developing cities. And cities need to invest in improving wages of this sector and not see them as a burden. Now, simple registration and access to state subsidies for all informal workers would have helped. India has a very efficient Food Security Act. A universal access to food can be and needs to be accelerated. Universal access to safe water and sanitation is urgent and has been advocated since decades by activists and academics. It is basic to ensure good public health, and one need not wait for an epidemic to bring that out. It is important that waste picking and other marginalized communities are also included and have a say in what is planned for them. Inclusiveness will allow for better practicing of preventive measures and allows for adaptability. It's also important to invest in processes for communities to be organized. Now, communities have some kind of organization, and if not, then it's too difficult. It's not very difficult to encourage to do so. And it has been demonstrated that it's much easier to work with organized communities, and we've seen that. Now, such organized communities are absolutely essential if an outbreak has to be tackled. Experiences of community-led practices, information dissemination in, like, say, for instance, the Ebola crisis in West Africa in 2014 speaks for itself. So when encouraged and engaged with organized communities, they often come up with local versions of quarantine, screening, ensuring food security, etc., what works for them, which is important if the spread of the infectious diseases need to be contained to prevent fatalities. Now, lastly, if reducing mortality is the primary goal of actions arising out of an outbreak, it is very important to assess and ensure actions of containing the outbreak do not result into parallel fatalities, because everyone was just too busy addressing the outbreak. So with that, I would like to close. Back to you, Bashira.
Thank you, Shruti, for the wonderful presentation and also sharing the experience with our speakers in India. So now I'd like to request our Sierra Leone team to share their experience. Thank you.
Good morning, everyone. I am 𝐒𝐿𝐭 from the Sierra Leone Urban Research Center. I'm here with Samuel, my co-presenter from the College of Medicine, and also some SLOC staff, Executive Director, Dr. Joseph McCarthy, Director of Training, Mr. Kuruma, and Mary. So our presentation is actually focusing on the urban trajectory and how unaddressed health priorities and community priorities are leading to vulnerabilities, and then compounded by the current COVID measures, in Freetown. Next slide, please. Next slide. Okay, so looking at the urban trajectory in Freetown, we can see that urbanization has been spreading at a very rapid rate. Now, between our two censuses in 2004 and 2015, the urban population has increased from 36.7 to 41%. This is as a result of urban populations coming to rural populations coming to Freetown in search of economic opportunities. So as a result of this, the number of informal settlements has increased about 68, and they are very dense, hosting about 35% of the city's population, living in poor conditions, lack of sanitation, and crowded situations. Next slide. And then this one is also compounded by the fact that the government has a policy of not recognizing informal settlements to address the existing situation. So as a result of lack of planning, informal settlements lack basic social services like water, sanitation, and then the housing institutions are very crowded. So this in many ways inform the kinds of policies that are implemented because of lack of understanding of the situation, and then refusal to accept the problem head on and address it. So for example, a recent National Development Plan does not have clear strategies as to how to address the mounting challenges within the informal settlements, and the fact that our national statistical data do not privilege the challenges that are happening within the informal settlements. So all of these situations are actually making the informal settlement situation very difficult to inhabit, and inhabitants are becoming much more vulnerable, particularly in this period of COVID. Next slide, please. Yeah, so looking at the public health priorities over the period, we have seen that there have been a number of strategies aimed at addressing perennial health challenges in the country, in urban settlements, but in many cases, these strategies do not privilege informal settlements. And so, for example, there have been review of national health policies to ensure that the health system is strengthened, and then to ensure that there is compliance with infection control measures, particularly after the Ebola, where we saw that there was massive spread of Ebola within the informal settlements because of these same challenges of overcrowding, lack of access to sanitation services, that kind of thing. So the public health response has been there in terms of having policies, but those policies have not been able to adequately address the informal settlement challenges. So looking at how those unaddressed challenges have been there, they are very, very much affecting the COVID response as it is right now. Next slide. So in addition to unaddressed government public health priorities, there have also been unaddressed community challenges. Those challenges including lack of access to water, health services. So these unaddressed challenges become compounded and unaddressed, and sometimes they become very complex to address. So things like access to water is very acute in many cases, and there are also cost implications in accessing them because most of informal settlements are not connected to the national water grid. So they are usually accessing water from the off-grid services, which are in many cases untreated and not very pure. Next slide. So this is a photo of a recent lockdown in Freetown where we had 3 days of lockdown, and before that there was another lockdown. So one of the acute challenges that was experienced during that time was the fact that many residents in Freetown did not have access to water because the spaces are limited, so many houses cannot be able to stock up water. And it was even much worse in informal settlements because they traditionally do not have access to water. And so there was a challenge of having water to wash hands, challenge of ensuring that people maintain sanitation. And then there's also a challenge of, in some cases, having a trade-off between paying for water and then accessing food. So it's a whole complex of, it's a whole situation of complex vulnerability that informal residents are facing in Freetown. Next slide. And then also the fact that informal settlements, informal residents are challenged with access to water, so to health services, because health services are, inadequately spaced. So people do not generally have access to health services. And then poor infrastructural services are making the fight against COVID very complex and difficult. Next slide, please. And then also livelihood situations and housing situations also make the situation very difficult to maintain social distancing because people live in congested, dense settlements. So it's usually very difficult to maintain social distancing. Next slide. Now I'll hand you over to Samuel to explain some of the current measures and how they are impacting on informal residents.
Thank you very much, Abu. Good day, everyone. And I am Samuel Saidu. I work for College of Medicine and Allied Sciences under the project of ARISE as a research assistant. So currently, there are measures already set up in Sierra Leone like other countries. One is the national curfew, which runs from 9 p.m. to 6 a.m. daily. Inter-district movements are restricted, so you have to get an electronic pass before you are allowed to move from one district to another. There have been 2 nationwide lockdowns. One was done in March and April, and another was done in May for 3 days each. And that was like 24 hours lockdown. No one goes out and no one comes in. Social distance measures have been put in place, like the previous speaker, Dr. Lilian from Kenya, said there are restrictions in number of passengers in cars and buses and even in meetings. IPC measures have been going on like other countries where people are washing hands with soap and water and also using hand sanitizers that are alcohol-based. And these are all coordinated by EOC. Next slide. There is an impact on informal residents. So when these measures have been put in place, there are usually closures of small businesses. There are limited access to water and sanitation services. There is rise in food prices as well because of there are less movement of people from the district to the capital city, loss of livelihoods by domestic workers, and there are also livelihood loss due to closure of certain means of transportation. We have food transportation coming from certain part of the district through the river lines, through the sea, but now it's being closed. So therefore there are no movement and therefore limited food supply in the city, leading to rising food price. Next slide. Community actions towards resilience. Community group have been mobilized. One of them is FEDUP, the Federation of Rural and Urban Poor. Other NGOs also have been actually putting in place measures that are very timely and that prevent risks, especially in risk communications and other health campaigns. Facilitate information flows from government to communities by community members and also NGOs. Next slide. So with this final slide, these are lessons learned for future emergencies. We think emergency measures must be pro-poor. That means it must include people who have been marginalized, and it must include people who are in their communities, and planning should be done with them. Provision of water and social protection measures should be put in place, and that should be community owned and sensitive. Community knowledge and structures must be integrated in emergency response plans. So therefore, people in the community must take part in the planning and preparations for emergency responses. Planning of informal settlement to address health and sanitation priorities should also be key in any healthcare planning and national development plans. Utilization of data generated from community groups to inform intervention response should also be taken into considerations. Thank you very much. I think this is our last slide.
Thank you so much, Abu and Samuel, for sharing this wonderful presentation and also what Sierra Leone is doing and what are the challenges you are facing. So now we would like to open this for the discussion. So we have got some questions in our chat box, and some questions are specific to some speakers, and there are some questions which we need to have further discussions on. So first, I would like to ask Lilian some participants actually posted some questions for Lilian. So one question about that, the use of masks. So how that is preventing, or that can prevent transmission. And another question was about the quarantine and social distancing issues, that how Kenyan people are responding to that quarantine and social distancing. Lilian, over to you.
Okay, thank you, Chair, and thanks for the questions. On the issue of masks, the guidance is, of course, we know there's no evidence that it can protect you from acquiring it, especially for the reusable masks. People are using the reusable masks, but it's helping in preventing people from, when you cough, from spreading the droplets further. So it's more of preventing or being an obstruction towards the coughing, because people's cough etiquette is not very good. But we know it does not fully protect you from acquiring the virus. So it's still important that even with masks, people do hand washing, the physical distancing, and continuous disinfection of the surfaces we get in touch with. The big challenge that there is with COVID is touching, especially the face, and touching surfaces and the face and the mouth. So those are things that are still being embraced. One challenge we've seen with the issue of masks is people wear them for the police, in terms of they'll wear them to cover just they'll put them on just to prove that they have the mask so that they're not jailed, but they will not even cover their noses or mouths. So we don't know how effective it is, but at least it will help in terms of preventing that spread. On the issue of people, the seriousness of taking their quarantine or social distancing, that has been challenging, especially in the informal urban settlements where people are crowded. When you drive around, you'll see people are still in groups or sitting close to each other or interacting very closely. There's inadequate space there, but there are also a lot of people that we've seen, and it's part of the myths and misconceptions we've collected, who still don't believe that coronavirus exists or it affects us, or also have the attitude of, it's just, what's the big deal? I have bigger issues to deal with. And that has remained a key challenge. The ministry addresses it in their daily address, and they keep talking about it. And community groups help to try and mitigate that, but it will continue to be an issue. And quarantine, as I've responded in the chat, has also been challenging in terms of the facilities where people were taken for quarantine have been public health institutions or public schools mainly, and people feel the conditions are not sanitary enough. The toilets have been shown to be dirty in some cases, and people are also crowded. There's no proper separation of people. So there's been a lot of people getting close to each other or interacting closely. Women and men are not segregated, or there's no security to protect them. And generally the attitude has been that I do not want to go into quarantine. So people are hiding from that. And we've had a few people escape from quarantine and tracked and taken back in. And the worst, then the final bit that most people were scared of was the cost. Whether you were exposed involuntarily or not, you had to pay the equivalent of $20 per day for the 14 days. And that was beyond what most people have the capacity to afford. So those are some of the challenges that we've seen. Though the cost is now being taken over by government, and they're now working on modalities for home quarantine, the services are still continuing. Over.
Thanks, Lilian. You raised actually very important issues regarding the quarantine and social isolation issues that people are escaping out of fear, and also the payment system. So I think that this is something we can also discuss, and I would like to invite our speakers to talk about this, that in their countries, what is actually happening. This is a serious issue. In Bangladesh, we're also facing not the payment, we don't have payment, but the fear and also the stigma and misconception regarding quarantine and social isolation. So I'd like to also now invite India and Sierra Leone to speak about this. And also Dr. Hossain, if you also have some insight about this issue. Thank you. India, Team India, do you have any comments or anything on this issue regarding quarantine and social isolation?
Bashira, I went off in between. Your voice is breaking. Could you just repeat the question?
Sure. So that Lilian was discussing about what is happening regarding quarantine in their country and in Kenya, that people are escaping from the quarantine center because of the fear. So what is actually happening in India context?
All right, so we were doing this discussion with a lot of different states and cities in India, asking communities their experiences. So one of the things is true, that there is a sort of fear of moving into quarantine, because in many cases there was a fear that going into quarantine you are more likely to get the virus, and there were also instances where people were saying that there is a sense of fear and not proper understanding of what quarantine is and what it does. There's also a social stigma around it. So people from lower communities, they feel that this is being done on purpose sometimes. So there are these kind of misconceptions and also sometimes happening in reality in a lot of cities in India.
Thank you, Shruti. Sierra Leone team, it would be better if you can also share that what is the situation regarding this quarantine and the reaction of people about this in Sierra Leone.
Mm-hmm. Yeah, sure. What is happening in Sierra Leone is in cases of quarantine, it's not quite different from the Kenyan case. Because COVID is a kind of disease where most individuals do not show direct symptoms like coughing, high temperature, or difficulty in breathing. So what happens, people really, when you tell them you are positive, if they are tested because they were last contact and they show positive, then they will tell you, no, I am not infected with COVID because I am not sick. So people are escaping from quarantine because of these reasons. People do escape from quarantine as well. There are other challenges related to the quarantine issues like food supply, water supply, because this is a country that also has issues with those social amenities, water supply, food supply, electricity, and all of that. But for self-isolation, initially what was the plan was government implemented what level of isolation measures. So for example, if you are an embassy or an international organization staff that comes to Sierra Leone and you are infected, working in Sierra Leone, they try to put you in the self-isolation in an embassy or the organization's designated facility that is being approved by the National Emergency Operations Center. So the EOC try to assess those facilities, and when they think it meets their standards or protocol that they have set, then they will allow you for self-isolation. It also goes for individuals. If they think you are capable of abiding by all the protocols set by the Ministry of Health and the government of Sierra Leone, then they can allow you to be self-isolated. Otherwise, they have to send you to a designated isolation facility that is set by the Ministry of Health through the government of Sierra Leone to get this self-isolation. But initially, for informal settlement, what happened was these communications were almost the same for like formal settlement. So if you get the same communication that is happening from formal settlement to the informal settlement, then it becomes complicated. Then they will tell you, no, we are staying very close to the Atlantic Ocean, the sea, so we get cold all the time. So we are not really infected. We are just suffering from our normal conditions that we usually have. So the communication was initially not really tailored to their own settlement standards. So that brought in a lot of complication when there were false cases they detected and tested positive in one of the informal settlements called Susan's Bay. So people were not agreeing. People were not agreeing to be isolated. They were not agreeing to be quarantined, and they were not also agreeing to be taken to treatment centers. So it posed a lot of challenges. But later on, there were invitations to get people actually who understand how to set up these communication measures that was exactly tailored to these informal settlement residents, and it was later accepted, and things are moving on. Well, not 100% well, but so far, yeah, that's how the measures are being taken.
Thank you, Samuel. Dr. Hossain, so if you would like to also tell something about what is happening in Bangladesh context.
All right. I think there are some differences compared to particularly the African situation regarding we haven't had a focus on institutional quarantine here. From the beginning, it was more focused on home quarantine. So that's a type of difference. But I think in the Bangladesh context, even the word lockdown wasn't used. I mean, government has been, in a way, has been balancing the focus on the need to do, to address the COVID-19 as a health crisis, but also to ensure that the economic crisis coming from the COVID-19 crisis also is addressed at the same time. So on the lockdown issue, we have what's called a general holiday with restrictions. That's the language which has been used. But one has gone back and forth in terms of the ranges of degree of enforcement of this lockdown situation. One thing I think which has mattered, and I think this is I would say that to Bachera and the ARISE initiative, is that there is a good research opportunity here to understand the diversity of ways in which the lockdown idea has been enforced in many. For example, as I said, in Bangladesh, it's a semi-lockdown situation, but in one crucial indicator, the lockdown has been rather, in a way, strict, which is about intercity transportation. So that between cities, between sections, the public transport has been, effectively stopped. And that has been a way of trying to contain the infection within hotspots and not allowing it to be spread. Though some of it initially did happen, but even now we have a very relaxed sort of a lockdown situation, but the public transport ban remains. Though people can travel in, say, private transport or some other means, but as a whole, I think this has been an important difference in the Bangladesh context. The other thing is about, I think issues came up about how to understand quarantine, how to understand the issue of mask. And I think these again too are important. I think it would be also useful to see, has there been innovations on the ground in terms of types of masks actually? For example, we have been talking of the protective equipment for frontline health workers, but there has been also been initiative here for protective dresses for the sanitation workers. Some groups have come up with trying to customize protective equipment for sanitation workers. In fact, myself, I have taken initiative for 16 municipalities to provide protective equipment for their sanitation workers. So that's also an issue that we should have a look at. In the Bangladesh context, I think the other thing that we did, which is very important again, is that the importance of rapid response research. We, in fact, my sort of research organization, PPRC and BRAC, Institute of Governance and Development, we together carried out a very fast research on over 5,000 households. And here also we had a methodological innovation because we really resorted to telephonic interviews. Now, usually as researchers, we thought that telephone interviews in countries like ours may not work. But as a part of the COVID-19 rapid response research, we see that it has great value, and our report has attracted a lot of attention, including from the government. We, for example, came out with two very important findings. One was that there's a distinct and great drop in income, which everyone is talking about, but we gave a figure actually, about 75% drop in income between February and April among the rural and urban poor. Urban poor, in fact, the drop is even higher. And the second point that we came out of our research, which is again, analytically very interesting and important, is that people who are above the poverty line, who are normally government, when they talk of our countries, they said that 20% is below the poverty line, with the idea that the rest 80% are, well off. But I think COVID-19 has shown that within the non-poor, there is a big stratum who are actually very vulnerable to crises like this. And we saw that about 80% of people living about, say, 40% above the poverty line fell into poverty again during this crisis. And we are calling them the new poor. And government also has taken note that something has to be done for this group also. So I think this is an important issue. The other point that I think should be seen as a research issue, not necessarily a health issue, but again, it is partly a health issue also, but also an economic issue, is the challenge of this last mile delivery. We have the programs, etc., but how to reach that last mile in terms of how to list people, etc., etc. That's a governance issue, again, very important. In terms of, I think, in the Bangladesh context, the other point which has possible cross-country implications is the fact that some of the social distancing behavior issues is not just a behavior at the individual person level. There are logistical issues here also about, say, community hand washing stations. And there has been BRAC, for example, has put up some of these. Other organizations like WaterAid has put up this. We are in fact trying to advocate for the upcoming budget in June, to try and give some attention to specific allocations for community hand washing stations, particularly for informal settlements. I think those are also some of the issues that one can talk about. Additional innovations, I think that's Kerala in India did that innovation, which is about how to enhance the testing capacity. So use of booths to try and collect samples. And BRAC has been requested by government. They have already established about 50 and more may be established. These are booths in which people can go easily and give their samples for testing, but there is a challenge remaining of increasing the lab capacity for testing also, to ensure that we just don't collect and then don't forget to, provide the results. A very important issue has come in the Bangladesh context, and I think what I heard from Sierra Leone, from Kenya, and partly from India also, is that how important it is to get the communication right from the very beginning. Because we also had many, and we continue to have some very gaps. I have seen that the presentations from the two African countries and also India also have, I think, highlighted this. The communication gaps has resulted in the Bangladesh context in a peculiar problem, that the non-COVID illnesses have got a hit, in the sense that private sector has broadly retreated. Private sector provision of healthcare has broadly retreated, and the main victim of this has been the non-COVID illnesses of people. They have taken a hit, and we have horror stories of how people have been moving between hospitals even for emergencies. So I think a critical common issue that perhaps ARISE can focus on is the importance of getting the communication right and what should be the content of that communication. So I think that's also a very, very important issue that we should be looking at. I think from now, for the moment, Bachira, I'll hand it over to you if there are more comments from the others.
Thank you, Dr. Hossain. Shruti, you wanted to add something with Dr. Hossain. It's over to you.
Right. So I wanted to add something is, first of all, we need to understand that.
Can you speak up a little?
Right. Am I audible now? Right.
Yes. Now.
Okay. So first of all, we need to understand that quarantine is a very big word. It is something that is new for a lot of people. And this situation in COVID is a new experience for everybody. And so it is for the vulnerable. Now, preventive measures that are in place is also mostly elitist, because poor people have very limited choices. So like, for instance, to maintain physical distance, as we say, one needs to have more space. And a lot of people have become victims of being beaten up by the police for coming out of their homes, because somewhere we haven't acknowledged that these houses are so densely packed that one could feel claustrophobic being inside. In many instances, people do shifts. So there are a set of people who live in the day and then in the night. So imagine putting all of them in under one roof and asking them to be there in a lockdown mode. Things like to wash hand for 20 seconds 20 times a day also means that one needs to have good uninterrupted water supply for 20 minutes. So all of these things are also very elitist, and it may or may not always work for poor people. This whole thing of having fear of quarantine also comes with the fact that these are things that are new. It hasn't been heard. And also in communities where, say, people are organized, there has been efforts made by leaders to help them understand what is the difference between isolation and what it means to be quarantined. Now, the media has also played a very important role in showing what's happening. But I think if the media had also shown institutional quarantine, so people would have had a better understanding of what this looks like to be better prepared. So the situation was very bad in the beginning, but I think over time, people have understood what it means to be isolated versus quarantine. And that there is this, this understanding has helped escape that fear to a large extent. Thank you.
Thanks, Shruti. Yeah. So yes, so the discussions regarding the recommended interventions, actually how feasible those are in the context of informal settlements, we need to rethink about that. And also that Dr. Hossain rightly pointed out about the communication and also the messaging, because in many of the researches, including in some research that BRAC School of Public Health is also conducting, we have found many misconceptions regarding how people are interpreting the messages that are given to them. So, and also one of the participants raised one important issue regarding that whether the informal settlements are actually been included in the country's COVID response plan or not, and what can be done in this regard. So now I would like to actually raise this point for the discussion with the speakers, that in different country contexts, how much these informal settlements are actually being focused or given importance in the country's COVID response plan. So first I would like to start with Dr. Hossain, and then I will pass to our three country speakers. Dr. Hossain, over to you.
I think to some extent, this will be a carryover from pre-COVID time as to how much urban poor focus the country's policy planning process has been. And as a whole, we know that there has been sporadic focus, but for example, in the Bangladesh context, we know that the urban, on the healthcare, we have a fairly elaborate health infrastructure for the rural population, but not necessarily for the urban poor population. There is greater healthcare in cities, but it is also more expensive. So it's not really accessible to the urban poor. So in a way, the urban poor settlements being included in COVID-19 response, one important area has been more in the area of economics rather than health, in the sense that there has been a lot of focus on the distress due to the lockdown, the economic distress, and the need and the emerging food insecurity crisis. So I think there has been, as I said, in the Bangladesh context, much of our safety nets were mostly for the rural poor, but in the COVID-19 context, the government has come up with some additional new programming for the urban poor also, but there needs to be done much more here. So, but in terms of the health issues, again, as I said, the hand washing stations, that has as an issue coming up. The water, ensuring water, these are really, it's very unlikely that these will be settled just as a response to the COVID-19 experience. These have to be a longer term solution for, in the way that our development planning happens. So that's how I think the urban informal settlements, but I would like to stress here an additional point here is that I think the programs like ARISE and the others associated with this, there's an importance here of translating all these experiences that we heard today into actually a policy knowledge by which we drive, try to influence the policy process. As I mentioned, our rapid response research really brought into the focus this idea that there's a new category, the new poor. There is people above the poverty line now who have fallen to people like a rickshawala or a small shopkeeper or a clothes shop workshop or a saloon worker. These are people who are not normally within the poverty planning exercise. But I think now they are beginning to be, they have to be considered. And I think it's Smruti who mentioned from India, I think. This, the fact that the ideas of social distancing, etc., has a Western elitist origin. That is true. But on the other hand, the need for some sort of a social distancing, hygiene, etc., is also there. So I think there is an opportunity here of really formulating an agenda on social distancing and hygiene more relevant to our context. A specific task of formulating that. I think that should be an important concern, an important challenge that we should embrace. Over to you, Bachira.
Thanks, Dr. Hossain. And now, Lilian, would you like to add something on this from Kenyan context? Lilian, over to you.
Sorry, I was trying to unmute. Yes, so I would like to add that the things that seem to be very similar, but in terms of looking at the response for among the informal settlements in Kenya, that was one of the considerations in the task force and in the thinking of the government right from the beginning. So the key concern there was how can they provide food, clean water. So for at least this time we saw water being delivered in the informal settlements. I don't know if that has sustained through this process since March, but I know initially we saw trucks delivering water there because that was a big concern. And then there has been food distribution by government and other agencies, a lot of NGOs and all have come together, but that has resulted in some stampede in some cases. So now it's very controlled. The key challenge we've seen though is, in my opinion, not inadequate involvement of the community to also see how best to implement some of those responses and to remember those who may not be easily available. So for example, the government provided a cash transfer program. It was a build-up of the one that existed for the elderly. So they wanted to get those who are vulnerable in the communities, in the slums themselves, to benefit from a cash transfer from the government. And they considered those who are older and maybe those who are maybe orphaned children. But when we had conversations with the informal settlement dwellers, their challenge was there. And just as Hossain has mentioned, the issue of those who are newly poor, they were working in a construction site, so they had a daily income, but suddenly that has stopped. So they are totally helpless, but they were not being factored in as people to benefit from, say, the food or the cash transfer. So those are some of the unique challenges we've seen coming up. There's a lot of work with community health workers, even in the informal settlements, but it has not been very well structured right from the initially, but now there are guidelines which are out and people have been trained to address that. But overall, there has to be more commitment and more to address the economic issues which seem to undermine the health benefits on the work that is being done, because the communities, in their opinion, their priority is hunger and food as opposed to masks and hand washing. And there's apathy now appearing. After a long time of doing this, they're starting to feel less interested and are less committed to maintaining these standards. So we need to really look at that. The other challenge I'd like to talk about is the issue of the reproductive health services and maternal and child health services. There's a risk, a very real risk that first, because of people being together in the homes and idle, we might have a lot more cases, or we definitely have violence, but we also have unprotected sex, and unplanned pregnancies may come up, and people are not going to the facilities. The facilities are open and have remained open. In Kenya, the private facilities have maintained the services, but most people will go to the public facilities. But as I mentioned earlier, the services there have not been maximum because of lack of PPE in some cases, or just fear that there are no services there. So we know that this will be some long-term effects that we will see, especially on that SRH and also HIV. Thank you.
Thanks, Lilian. So yes, Team India, please, over to you.
Am I audible?
Yes, Varun, please.
Yeah, so the policy responses in India with regards to informal settlements, we can see that there is no mention of waste pickers per se. And when we look at the larger city dwellers, what we see is that they're generally spoken in large terms, such as homeless, poor, or vulnerable, migrant workers. Now, the union government in India has not come out with a policy that is very specific. Rather, it's left to the states to decide. And what happens is that this again transcends down to civil society organizations and the local networks to facilitate. So the reach to civil society organizations, collective bargaining remains very crucial, and that should also be appreciated by the policy members, is one of the points that we would like to raise. Now, the current debates in India is largely about migrants, and currently is picking up a tone of migrant workers and how they have to how they are facing challenges in getting back home. But what it also misses out is the lack of access to healthcare facilities, which is already being crumbled at this particular point of time. And like how other speakers were mentioning, the private sector has completely packed off. Now, this means the health systems are at a strain. One more thing that I would like to add is that the informal settlements, again, has a large nature of heterogeneity within them. And also it depends on their location also. For example, the ones in, say, the urban areas have slightly more access to information or, say, some relief materials, whereas the ones in peri-urban areas are kind of left out. Now, the situations in villages are entirely different. What this raises is another question of how a situation is going to be after COVID, because we're talking about people who have had historical experience when it comes to exclusion and being marginalized. So their intersectionalities could be way higher, and there is a huge need to understand and recognize this from the policy perspective. And yeah, this is largely my response to it. I mean, our response to it. Thank you.
Thanks, Varun. And then now, lastly, Abu and Samuel, over to you.
Sure. For COVID response plan in the including informal settlement, it's just like the previous plans, the national development plans they have that have either no or very limited inclusion of the informal settlement, especially around Freetown. Most of the plans they have is eviction, so people have to move, and that is completely impossible. So we don't have a specific plans for that. However, if you look at the informal settlement like other countries, you see that they require hand washing, but there is no water in the informal settlement. You can't find water for hand washing. They also require IEC materials. These IEC materials are made generic. When they are made generic and you send them to the informal settlement, their educational levels are very low. Their understanding is very different. So who will understand this information? No one will understand this information. So hand-to-mouth living, we call it hand-to-mouth living. People live on daily bread. So like they go out today and they work and they find food, then they eat. Tomorrow again, they go to work and find food and eat. So if there are restrictions, then definitely you will have it difficult for them to survive. Of course, overpopulation, overcrowding is the order of the day in informal settlement. These are all measures that are not included in the plan. So you tell them to have social distance, that is not going to be possible. So if there were measures initially before now, or even during the response, there are measures taken, then it can actually be great. But so far as we speak, there are no specific measures designed for informal settlement. So that makes the response very difficult in that area. I think my co-presenter will add.
Just like what someone has said, I mean, in terms of the national plan, it seems like a one-size-fits-all. You know, messaging is not really tailored to the needs of informal settlements. But at city level, there has been some efforts by the city council to include some of the informal settlement representatives like FedUp. But that one, I don't know how far that one has actually gone in terms of planning, the process of and communication, the process of giving aid to informal residents, with the exception of the lockdown in in the first lockdown, there was collaboration for giving out food aid to the most vulnerable, the poor, and that kind of thing. But in terms of planning itself, generally, informal settlements are not actually privileged in how they are planned. At the initial stage, when we started to have community infections, we saw that one of the informal settlements, one of the biggest in Freetown, Susan's Bay, in a particular day, all of the infection rates were coming from that area. So community health responders went to that community to be able to have them isolated, but there was some kind of resistance. So it comes to the question of how the messaging had been done to ensure that those who are supposed to be, isolated will submit themselves and get willing to be isolated so that they don't infect other family members or community members. Somebody, you want to add something? And then also in terms of
Thank you,
isolation, I just wanted to add something quickly about the isolation. In terms of isolation, I've just been told by our colleague, Dr. Mansari, that government is considering to cancel or put an end to the institutional quarantining, which is eating into the national response budget. So that will mean that people will have now to be quarantined at home. But given the fact that the informal settlements, there is challenge of space, that one has a possibility of spreading infection very quickly. Thank you.
Thank you so much, Abu and Samuel. So, and we are actually running out of time, so I'm very sorry that we cannot take more questions or have more discussions at this point, but those are very important and very interesting discussions happening. Now, I would like to request Dr. Hossain to say the concluding remarks. Dr. Hossain, over to you.
Okay, thank you. I think this was a very useful sharing of information and insights. And I think we have covered a fair amount of ground. Just as a concluding takeaways that we could work on down the line, I think one important issue would be to really document this, the experiential realities on social distancing, and how, for example, at what point in time changes in ideas have come. For example, I heard from the Sierra Leone, last was this idea that institutional quarantine is, they're phasing out to an home quarantine, which would be much, I guess, enforced in a much more laxed manner. So in terms of the social distancing, this whole agenda, I think it is, there is a larger global debate that whether many of these are ideas of social distancing have been drawn from elitist Western societies who have the resources, etc., to really fulfill many of the conditions for social distancing. But what is at the same time, we realize that in itself, that idea is important to try and contain the infection spread. So what does it mean? And trying to, in a way, use the experiential knowledge from these multi-country studies to try and come up with a sort of an agenda which is more relevant for country. As I said, for example, in Bangladesh context, it's lax lockdown inside cities, but fairly strong bar to public transportation between cities. That's one type of understanding by which this has been done. So I think that's an important issue. Another one is about the communication. I mentioned it before also. I think it's very important. And I think from multi-countries, we can really get a sense of what would be a more effective, because this crisis may hopefully end at some point, but we are looking at new crises which will come down the line. So the whole issue of communication and getting the communication and messaging right is absolutely critical. Third issue is about this, the economic distress is an important side issue here. Side issue, equally important, but it's a derivative issue from the health crisis. And I think there is a need for both research here, but also try and do something about it. Particularly, I think we need to, in terms of even research, we need to see whether, to what extent it's government or public policy which has been playing the role, or the social capital, or a combination of both, which has been responding to this issue, and in what manner. I think that's a very important issue. Finally, I would strongly urge that, I think at the very outset, the first first presentation talked about myths and misconceptions. That's a very important issue to keep in mind here, because there are still awareness gaps, but not among the informal settlement population only. There are awareness gaps within the government also, within policymakers also. So we need to have a final focus on that. Last, I leave everyone on that thought, is the idea of innovations. That under this crisis, are we also trying to, coming up with some new innovations, like the booth was an innovation idea in terms of response. Are there other innovations happening? Getting those innovations recorded would be a very important task. All right, Bachira, I would like to end there.
Thank you, Dr. Hossain. And this is the end of our today's webinar. I would like to thank all the presenters from different countries and also all the participants for asking many important questions and also raising some important issues that we actually we all want to resolve in this pandemic situation, to make the life of the informal settlement dwellers who are poor and mostly poor of the poor, to make their life a bit easier in this pandemic situation. So thank you all. And this was, I think, a very good discussion. And the whole webinar recording will be available after the webinar in our social media platform and Facebook and Twitter, and also in our BRAC JPGSPH School of Public Health website. And also all the, I would like to thank all the people behind who worked behind and arranging this webinar, my team members, my colleagues. Thank you all, and goodbye, and stay safe. Thank you so much.